Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our speaker tonight is Dr. Diana Shechtman, a board-certified optometrist who obtained her degree from Nova Southeast University. She's worked within ophthalmology practices for nearly a decade and was a full-time professor for 18 years at Nova Southeast University, where she served as coordinator of the Diabetes and Macular Clinic and director of interdisciplinary education. She's currently consultative optometrist at Low Ophthalmology and Associates, as well as at Retina Consultants of Miami. So please, a nice warm welcome for Dr. Diana Shechtman. Diana, why don't you take it away?
Thank you, Joe. And we'll get this little party of peripheral vitreal diseases started. I have to definitely thank Joe, not only for inviting me tonight, I really truly appreciate it, but also for teaching me and getting me involved in the little bit of the niche of the retinal world. I remember years ago when I was a student and later on a faculty with Joe, how I asked him that I wanted to kind of develop some sort of niche and style. And he's actually the one who mentored me throughout a lot of stuff. So thank you, Joe. And it's wonderful to be here tonight. Disclosures are not much. I used to lecture quite a bit and been part of various different industries, but nowadays most of my lectures are involved with OD, MD, collaborative care, and within the virtual perspective or the platform, because I really want to try to educate and levitate our national status, as well as to more or less bridge the gap between ODs and MDs alike. We are going to try to discuss each and every one of these entities. And as many of you guys you have in front of you is an outline. You did not get my PowerPoint presentation primarily because all these are actual cases of mine to disseminate, but particularly slides such as this particular slide with specific words, I am happy to send to you, including the AAO, the American Academy of Ophthalmology, not optometry, newest guidelines, which are called the preferred practice patterns. And we're going to touch upon each and every one of them, because if you were to have a misdiagnosis or a lawsuit at hand, many of these come with the standard of care. And whatever the standard of care is really the care within the practice around you. Is that correct, Joe? I mean, do we always have to oblige with our AOA, our particular guidelines, or do we have to oblige within our community and what both ODs and MDs are doing in our area? And I know you deal with a lot of these, Joe.
The reality is it's a combination of everything. Now, if there are preferred practice guidelines in optometry or ophthalmology, those will be consulted in medical legal issues. And then it also comes down to what will expert witness opine as to what would be the standard of care of a like practitioner in a like situation at a like time that the event occurred. So it's all a combination of everything. You know, Diana, interesting. I think back to when I was a wee little tyke and being admonished by a parent, I think my mother, for doing something. I said, but everybody else is doing it. And her response was, just because everybody does it doesn't make it right. And my response was, but Mom, it may not make it right, but it does make it the standard of care, doesn't it?
That was good, Joe. That was very good. So in essence, we are going to touch upon primarily.
What do you mean? It's a true story.
It was a great story. I still thought it was a good story. But in essence, what we're going to discuss here, our AOA guidelines actually date back, if I'm not mistaken, 2015 or 2019, and new standards haven't changed. AAO's preferred patterns seem to change at least annually, if not every 2 to 3 years. So I am going to touch upon quite a bit on the latest ones, and everything here will be discussed. Number one, this is not a poll question. I'm just kind of getting a little bit of any understanding here, but the number one overlooked issue in the eye, by far, I would have thought people might have said cornea or lens, especially if you kind of deal with the periphery, you use the lens or the cornea collector and you move right through it. But in reality, it's the vitreous. The vitreous is actually an incredibly important area in a cavity within itself, particularly when dealing with retinal breaks, PVDs, etc. And often we write clear, like we write perla with pupils. But let's be honest, when is the last time we truly tested think many of us do. We just write out the word. So I'm going to touch upon a lot of areas within the vitreous and discuss some of the aspects at hand. I found this video to be cute because this actually happened to me. I was at the beach. I looked up at a beautiful blue sky, and all of a sudden, I'm like, wait a second. Is that what I think it is? Am I seeing my first floater? Unbelievable to think that at age 32, I have a floater. Okay, never mind. I'm really not 32, but we won't go there, Joe. Closed one eye, looking at this little guy, and just like any patient, try to stare at it and try to find it again. But every time I were to look at it, it actually moved over.
I really need the money, and I don't have the credit for a bank loan.
Do go, because if you got to work here any longer, you're going to feel smaller than my eye floaters. Here's one now. You can never look at it dead on. It's always trying to get away. Hey, eye floater.
Hi.
Hey, where you going?
Away from your pupil.
Well, maybe I'll look over here.
I'll go over here.
You got an answer for everything.
Oh,
I actually found that quite funny because I've actually experienced it. And it really is, comes to a floater, it really does float in the vision. And I think these are important points to get out of the patient. I've had patients who come in of a leaf-like floater in their vision, but they were actually talking about a scotoma. Floaters in itself should move with the line. Numerous floaters is not the same as having one or two floaters in the vitreous. And if it's a floater that a patient's had for quite some time, I'm not as concerned. But an acute floater, one that they just identified yesterday or today, that does turn me a little more to just keep a watchful eye. Another thing I think it's important to note is a conversation with the patient. Haven't you been told before to a patient and you say, hey, you have a PVD, you go through this whole entire explanation, what it is, what you have to look into, and you've had a patient leave and call your office the next day and say, you know, the doctor told me I had a detachment. Why didn't they do something about it? The only thing they heard was they didn't hear posterior, they didn't hear vitreous, they just heard detachment. They go to Dr. Google, race home, evaluate everything there is to know, and now they think they are completely knowledgeable on everything there is to know, and they only was a PVD. So I often call it dehisce or separation of the vitreous in order not to confuse it with a retinal detachment. Which is I'm in my 50s, does increase to 50%, 50s, goes on to 60 in their 60s, 70 and 70, 70% in 70-year-olds, and so on. So with age, the chances of a PVD is more likely to occur. Occurring in younger patients, secondary to or a history of trauma. So, typical patient here. I am certain that many of you guys, unless you work in a pediatric practice, within 2 weeks had somebody who complains of a floater. It is the #1 diagnosis symptom in our office at a retina practice. Just like in a general practice, maybe dry eyes, itchiness becomes a very common entity. Floaters is the #1 thing most of patients are either to our practice. The 65-year-old really has an onset of floaters 5 days ago. Asking questions regarding flashes and how many floaters, describing, I think, becomes important from a clinical picture. Here you can see the perfect, almost white appearance, both in the optus and right behind the lens, as we mentioned, within the vitreous cavity. I caught it. Now what do I? Well, it's basically the identification of this particular floater, or knowing not incredibly high, does have a chance of having a retinal during the acute state nature. When it comes to the preferred practice patterns, what's a note is that the actual retinal break, if there were to be one, is at the time that the PVD occurred. It is not thereafter. As a matter of fact, if there's truly no break initially, the chances of a retinal break thereafter minimize to only about 5%. Even though we're following a patient during a routine time, we're probably following a patient to give ourselves a second chance to find that break, because you should the initial first time. Up to 1 in 5 patients could have a retinal break in the PVD process, but this kind of ranges anywhere between 8 to 20 patients. And as I mentioned, thereafter, when you follow up the patient a month, 2 months out, the chances of a retinal less than 2 to 5%. And it's typically either missed or a new one. When should we follow up a PVD? Joe, what's your guidelines? What do you usually do for your patients in regards to a PVD follow-up?
Well, that's interesting, Diana. I'm gonna give you a little background because when I talk about this topic in audiences, I poll the audience to see what they like. And some people say 1 week, 2 weeks, 6 weeks, 8 weeks, 3 weeks. There is no consensus. All right, so I will tell you that my approach is 7 to 10 days. And here's why. This is out of probably 200 malpractice cases that I've been involved in. Alleged misdiagnosis of retinal detachment is the most common thing that I see. So I've seen a lot of these cases secondhand, and I can tell you the majority of cases that have gone bad, that have resulted in malpractice cases, virtually all happen within 2 weeks of the event, and about half of them within 1 week of the event. So if you bring a patient back at 4 weeks, my recommendation is bring them back sooner. My approach, if there's no vitreous hemorrhage, is 7 to 10 days.
And Joe, I actually think you hit the nail on the head. Now I'm giving you again, I was going to allude, as I mentioned earlier, to the newest 2024 guidelines from the American Academy of Ophthalmology, which do go into the 4 to 6 week standard that most of us have considered. But I actually love your approach. And I do believe that is important. Primarily, just we probably missed that original break the first time that led to an RD, and you're much better off finding something in about a week or so where there's still a break or an RD macula on or a small retinal fluid than a month to 6 weeks later. So I often follow the second round, which is the 1 to 2 weeks. Not when there's a vitreous hemorrhage. To be honest, and I work at a retina clinic, when there's a vitreous hemorrhage, due to the fact, and we'll touch upon this a little bit more in a later slide, but due to the fact that you're dealing with a very high risk of a retinal break being around there, anywhere between 50 to 75%, I often get my retinal specialist second opinion. He's right there. My other retinal specialist, Dr. Kunker, is right there. So I would definitely urge you to get a second opinion if you see a hemorrhage and you don't see a break. And honestly, I probably follow Joe's advice that within 2 weeks, 7 to 10 days, it's probably a good idea, not necessarily because the process occurred, but it gives you that second chance to look at the retina carefully and find that break that could have potentially been missed the first time around. And I'm going to show you some of these cases at hand.
Now, before you go on, I just want to kind of qualify vitreous hemorrhage. Now, if there are areas where I can't see the retina because of vitreous hemorrhage, I agree with you entirely. That's the case that I'm gonna have our retinal surgeon look at. And interestingly, I've actually seen how photographically how much improvement can happen in 24 hours in terms of visibility of the fundus. Now,
True.
Diana, would you outline with your mouse that vitreous face there on the optic nerve?
The vitreous space?
The face, the Weiss ring.
Oh, I'm sorry, the
Okay.
face. Yes, here we go.
Most of these should be fairly hard to find. It's what I call looking for a ghost in a cellophane factory. It should be hard to find. Now, if you see pigment on it, that's not pigment, that's blood. You know, I frequently will get a hemorrhagic PVD where I see blood on it. That is usually blood off the disc capillaries. Now, for me, the most important view in the fundus is inferior mid-periphery when I'm examining a patient. And that's where you're going to see an accumulation of pre-retinal blood. Now, I look at patients upright, and when I see something like that, I will recline them. Diana, in virtually every case where I've had inferior pre-retinal blood in this situation, when I recline the patient, I lose it. It just spreads out. I don't see it. I will sit them back up, let gravity take effect. A few minutes later, I'll see it in the upright position. So I will look at the patient upright and reclined. I will say whatever lens I use. If I see the Aura 360, I write it. And if I do scleral indentation, I write it. That's all very important to protect yourself medically, legally.
Excellent, excellent point. And great, Joe. And I'm glad that you brought up the scleral depression. That is definitely a good, because our guidelines, as far as the AOA, really state that scleral depression should be done when you feel necessity. On the other hand, American Academy of Ophthalmology state to do scleral depression on acute PVDs, retinal breaks, etc. Almost like you stated, you do it on every single PVD. And more importantly, I write it and document that I did it when I did it at hand. And it had as a polling question to see how many people actually do scleral depress. I think most of us probably feel uncomfortable. And unfortunately, until you do it a number of different times, you're not going to get that comfort level. You need to practice, and you don't want to wait for your first patient who's got a mid-dilated pupil, 70-year-old woman, where you're telling them to look left and they're looking right. That's when you want to take it out for the first time, that you haven't used it for about a year. So I would urge you to start practicing, and the more you practice, the better you will get. It is a remarkable tool, in my opinion. It really does help you assess the retina in a whole different perspective. This is a view from a scleral depression on a shallow break. And what I mean by shallow is it was actually low lying. It's not necessarily shallow, but low. When you're able to open it up to some degree, see that it is a break. There's a hemorrhage here. So the vitreous, I wanted to show you the illustration, is pulling, holding this back, and the actual break is down here. Just like Joe stated, oftentimes you see some pigmented cells, and they may not necessarily be pigments liberating from the RP, as in the picture here. But if you're seeing something that looks like a hemorrhage, usually they're RBCs, or red blood cells. And anytime you see a red blood cell, the chances of a break are very high. Now, even if you don't find one, unless you feel incredibly confident, the only reason I would urge you to get a second opinion is because we have found in our practice micro tears, and those to a vessel can break and essentially liberate the vitreous hemorrhage and can't be missed. I just think because there's a high propensity towards there being a break, feel pretty confident and make sure that you definitely do a scleral depression. Scleral depression will not only help you identify a shallow RD, a flap tear that you're not sure, is it a tuft? What am I looking at there? It gives you that dynamic at hand. Show you a picture where it can help you identify a hole versus a hemorrhage, both looking red out in the periphery. And it can allow you to bring, like Joe said, he's looking out to the aura, but it would allow you to bring the aura more into your view, more peripheral retina into view. Here's an example of what a retinal hole versus a hemorrhage would look like. In a retinal hole, you're not looking at this 3 dimensions, but when you're scleral depressed, what you will essentially see is that this particular area here and here comes out at you like the mouth of a fish, and the tongue, being the actual RP below, will be inundated. And that dynamic, as you move it, you're able to perceive what you are looking at. So I find this to be an incredible, great tool. And I can tell you, my surgeons take out that scleral depressor 24/7. And Joe stated another thing where he looks at the patient in a dynamic view, which I like that, kind of bringing him down, bringing him back up. Oftentimes, if I'm having a hemorrhagic PVD seen by my surgeon, I let them know to sleep with pillows behind their head to actually bring the hemorrhage down. And you can see much better view, especially superior, which are very important to me, in particular if we have a retinal break in that area. And I also encourage you that after you look at things with BIO, you can take out your 90D lens. I'm not asking you to do a full peripheral, but the dynamics of looking at things through the 90 in a very high definition through the slit lamp really allows you to see small micro tears. I've found many things that I thought I did a fantastic job in my BIO with my 90 at hand. So just a couple of tips of what one can do. I don't want to really get into this too much. This is more of a tape to give you an essence of what you shouldn't do, and here's why. When you're doing a scleral depression, you're having a patient look at away from the line of sight where you're putting the scleral depressor. The area you actually hurt them is by doing what this person is doing right now. Because of that tilt, you're going to hit the plate. That's what actually hurts the patient. You want it to go straight into the eye and actually push into the globe. You're not pushing straight down. You're not pushing to the plate. You want to push into the globe to add that dynamic that you're getting. So do you often press, or at least when you find it to be necessary?
I'm sorry, you cut out for just a second there, Diana. What was your question?
I'm sorry, I asked if you,
Mhm.
did we lose me for a second?
About 2 seconds.
Okay.
So you're asking me, do I
You can never take back, Joe. I'm so sorry.
do
So
what?
depressed.
Do I scroll depressed? The answer is yes, it all depends on how I feel about the situation. If I think there is a high risk that there is blood, I'm going to do that. Something where I think that there is not a high risk, I often don't do that, but I always record if I do, and if I get a very good view and I'm at the or, I may not do that. Now, before you go on, Diana, there is a couple questions.
Yeah,
One
please.
person asked, if you can't get a pressure, would you still go ahead and dilate if a patient complains of floaters?
If I can't get a pressure, yeah,
Mhm.
100%. There's no
Yeah.
reason
Mhm.
I don't dilate. Often I will even dilate a narrow angle. If I feel
Mhm.
this necessity to dilate, I will, and I don't rely on just my photos. And I'm going to show you
Mhm.
that in some photos you can miss things. And I'll show you some cases about that.
And there's another question, where does the blood come in those percentage up to 30% of cases where there is no break?
It's still the blood vessel. The point
Mhm.
is, it wasn't strong enough to pull the rest of the retina with it. So the blood vessel is the only way blood is coming
Torn.
from.
Yeah,
The total-
torn capillaries.
Yeah.
And when you have that hemorrhagic vitreous face that looks pigmented, but it's really blood, that's from torn disc capillaries. And those are actually relatively low threats.
Yeah, they're about, I think it's less than 10%, about 8%, but then the other ones turn to about 50 to 70. So the bottom line is the odds are against you, but they certainly can happen without a break, still from the blood.
Mhm.
So I think this is a poll question, Joe.
It's a poll question. All right. So let me pull that up. So this will be poll number 1. So which of the following is not an ominous sign when counting acute PVD? Pigment on the retina, vitreous hemorrhage, pigment in the anterior vitreous, specks on OCT vitreous cavity. And remember to go to that poll icon on the right part of your screen to find the poll and see the poll. So which is not an ominous sign when counting the acute PVD? Pigment in the retina, vitreous hemorrhage, pigment in the anterior vitreous, or specks in the OCT vitreous cavity? Very good question.
Let me know, Joe, when we can move forward.
Yeah, I'm gonna let them come in. We're doing pretty well. I try to give them close to a minute or so.
Sure.
All right. Well, what is not an ominous sign? Majority say pigment on the retina at 64%, followed by specks on OCT vitreous cavity. Pigment in the anterior vitreous is at 9%, and vitreous hemorrhage is at 4%.
I'm going to hold that thought because we're going to get into each and every one of these at hand. So, diagnose PVD. In the anterior vitreous, you notice these, and they're different. Once you start actually looking specifically at pigment, what we call Schaefer sign, they look a little, you get a feel for what they look like, a little different in red blood cell, but oftentimes they can be mistaken. But let's say we're pretty sure that this is Schaefer sign, and you do a full examination. Patient hasn't had cataract surgery, iris is normal, everything is fine. And you feel you saw no breaks, no detachments, but you did have an acute PVD and you have Schaefer signs. In various studies at hand, what they have shown is that retinal detachments and or retinal breaks, and these are just a few of many examples, have a high propensity towards having pigmented cells. Liberations, particularly larger breaks, liberations of the RPE cells into the vitreous cavities. So a retinal break has 7 times more likely to have pigmented cells. These pigmented cells, also known as Schaefer signs or tobacco dust. So let me ask you, Joe, getting back to the case before, this wasn't you. This was any other doctor saw this case, swears there's Schaefer signs. He's going to write it on his records as pigmented cells in the vitreous, Schaefer signs, with an acute PVD. Should he just merely follow? Should he get a second opinion? Should he follow closer? Should he relook? What do you think? Because remember, whatever you have in
I think all the above is reasonable. I mean, if you're saying that, you are saying that there is a break there. Now you need to find it. And if you can't find it, you have to have somebody else try to find it. And it can be a colleague in the office, it can be a retinal specialist. You know, the more people that you have that say there's nothing there, the harder it is to say that you missed something.
And you hit the nail on the head at the beginning, Joe, and that's exactly my point. You were saying that the likelihood of a break being there is quite high. Now, if you're writing everything towards that, and then you state no breaks, tears, or detachment, it makes it that much more difficult to be able to defend such a case if a break were to be seen later on, or this patient does end up having a retinal detachment, because everything up to that point is a very high propensity or likelihood. So the odds are again against you. Another example of a case I just saw recently. Yes, Joe.
Interestingly, what will happen, I've seen in many cases where I've been an expert witness doing this type of exactly this type of situation. There will be a specialist, an expert witness, usually an optometrist, and the attorney will say, in all medical probability, the retinal break was there at the time of your examination. And because you did not see it, you fell below the standard of care. You were negligent. And those are the words that they need to have: below standard of care or negligent. Those are the golden words. And if they can get that out of an expert witness, a treating physician, even from the sued doctor themselves, that's golden. Unfortunately, that's not the law. Doctors are allowed to make mistakes. Doctors are allowed to be imperfect. Doctors are allowed to not have the utmost knowledge known only to a few in the profession. But what they can't do is deviate from other reasonable people will do. Now, Diana, you and I, and even the retinal specialist can miss a break.
Of course.
And it can lead to a retinal detachment.
Of course.
And it does not mean that you're negligent or fell below the standard of care. Now, if a person comes in with flashes and floaters and you don't dilate and look with an indirect ophthalmoscope, well, that is not what other people would do, and that would be considered negligent. But missing something, I hate to say it, the law does allow you to make a mistake.
Good point. Patient here, so talking about missing something, you kind of lead me to every one of my next cases. I like that. 3-week onset of floaters, worried about continuous flashes. I just recently saw this patient. Saw an ophthalmologist 2 weeks ago. So again, could have been an optometrist, it could have been another retinal specialist. It was a general ophthalmologist, diagnosed with PVD, asked to come back in 2 months. Patient was still rather nervous. He comes in to our office, and this was my retina clinic, and I was there as a second opinion. I take a look. Certainly we can see a PVD, and it's a little tough to see, but these little small specks, and unfortunately I should have gotten a little bit of a higher definition, epiretinal membrane, but there were quite a few specks in the actual area of the vitreous cavity. And in the optos, and this is our general view right now, we're not really seeing much. But if we have the patient look slightly off angle, there is actually a break. And then it becomes in question, was that break there 2 weeks ago? Did it occur now? I mean, granted, the patient was a little bit, should we say, frustrated because he felt like he was asked and came back and then just dismissed. Patient who is going to get upset, to be honest with you, at the end of the day, is someone who thinks you don't care. It's not necessarily the mistake you make, but the fact that you dismiss a patient or you ignore their problems, whatever problems there may be, that's the patient that usually gets upset. But regardless, we were able to treat the break, and the patient's done very well. You cannot rely on your photo alone. You will miss something. This is an off view, as you can tell where the nerve is, to be able to catch it at hand. But bringing me back to these value of these specks within the cavity of the vitreous, there's been studies, this is just one, there's few out there that does show that having at times during the acute PVD process, you do an OCT and you find these hyperreflected dots, that they in fact could be associated with an increased chance of a retinal tear. I'm feeding you the information because the more diagnostic data you have in front of you, the better you may feel about your examination or the fact that you may potentially need a second opinion. Numerous floaters. We kept talking about one general floater. And I, just like I said recently at the beach, experienced this beautiful, my first floater with a gorgeous blue sky. So oftentimes patients will begin to notice their floaters with a white background, a very clear. And there's usually one or just a few, but there's numerous floaters that looks like someone took pepper and shaked it all over the environment. It's a little bit of a different situation. Patient has lattice. And as you can tell here, you can see these numerous floaters going around and the 2 retinal breaks, including the lattice the patient had, which is going to bring about further information regarding lattice and the propensity to a retinal detachment. The lattice in itself and the small hole the lattice had, even though there's thinning and you have an opening that can lead to vitreous gel gaining access to the subretinal space, that is not necessarily a very high propensity, but the actual traction around that area with a strong area of adhesion can lead to a large break that leads to a retinal detachment. As a matter of fact, patients with lattice who have been found to have retinal tear at times, or even RD, sometimes ends up being in an area not necessarily within the lattice. So I need you to kind of understand the dynamics at hand. Getting back to what Joe mentioned about the retinal tears and the vitreous, here's an example to a third and probably more vitreous hemorrhages are related to a retinal tear. A lot of the rest of them are usually related to proliferative diabetic ret. So we're looking at 2/3 of vitreous hemorrhages being related to either PDR or a retinal tear. The rest are scrambled within small entities at hand, from a retinal macroaneurysm in a very small percentage to a PVD in association to the capillaries being pulled. Here's an example of a patient who had some hemorrhages, a very large vitreous hemorrhage. This is not a PVD, this is a vitreous hemorrhage, and numerous areas of traction throughout, and actually had I remember, if I remember correctly, it was 2 tears, right here and one here, but there's a bunch of areas of traction. So there's a lot of pulling going around, which caused this hemorrhage to occur. And Joe alluded to this as well. Most vitreous hemorrhages are going to settle in the inferior area. That is not what your retinal tear may be. As a matter of fact, chances of a retinal tear are higher to be superior over inferior, but most vitreous hemorrhage, and they're dynamic, so you can have them shake their eye, you can have them lay down, you can have them sit up, you'll see different views are going to eventually settle. This is why oftentimes if you don't tell a patient to keep their head elevated when you're trying to settle a vitreous hemorrhage, say in a PDR patient that a retinal surgeon is going to do PRP at a later date, they wake up and that day they feel they're blind because it's like shaking that snow globe in front of their vision.
And Diane, if you go back to that, is really just a classic photo of that linear inferior pre-retinal hemorrhage. Your diagram explains well how that happens, and that and you said the break isn't necessarily there. It could be, but it's not necessarily there. But that is what tells you to look more carefully. Do it again.
Very good.
All right. And that's why I say when I'm looking at it, and I had 1 or 2 cases today, nothing was hemorrhagic, but I'm looking at, I find the Weiss's ring, the vitreous face. My next most important view is look down. And this was with the BIO and 90, and I have them look down, and I'm looking for this. If I see this, I know I've got to work a little harder. I'm going to have to do scleral indentation, but I do mine upright. If I were to lay that patient down, and by the time I get myself situated, that hemorrhage is gone.
100%.
It has dissipated. I can't find it. That's why it's good to, in these situations, do an upright BIO and a supine BIO.
Excellent, excellent point again. Also, the density, and I've seen so many of these throughout the years, the density of the vitreous hemorrhage isn't necessarily associated with the chances of a retinal detachment and or break. So location doesn't help and the density doesn't always help. This one up here, as you can see by the ultrasound, granted it doesn't have every single view, there is no retinal detachment. And on this one, this happens to be my case here, you can see aspects of the optic nerve, and there's a full-blown retinal detachment. So the density itself doesn't always help you. And if you cannot see through that, then you have to get an ultrasound. There's no question that you have to get an ultrasound in a case that you can't see through it. As a matter of fact, I've had some of my surgeons do what they call exploratory vitrectomy. If it hasn't cleared and they're worried, they're going in with a vitrectomy so they can see what's behind there. Because unfortunately, an ultrasound can miss low, shallow RDs, and it doesn't always pick up retinal breaks. So when it comes to a vitreous hemorrhage, if it's a small one like the one previously, it's usually followed by, my retinal specialist probably follows out within a week. They usually don't follow PVDs very closely. I'll tell you 6 weeks at most and never see them again. But I do like Joe's Clinical Pearl. I think it's a good one. And it's, again, we're all human. We all can make mistakes. Let's give ourselves a second chance. And patients who are ANSI, the type A personalities, they're going to come back. Trust me, they want to hear that they're doing better at the end of the day. Ultrasounds should be done if you have a hemorrhage and you can't get good views. And a vitrectomy may even be done if the surgeon feels they're really still not getting a good view or non-clearing hemorrhage as such. Reviewing again, I encourage you to do scleral depression. I often do it myself, but it's up to you. The hemorrhagic PVDs, I encourage you to get a second opinion. We've seen plenty of them in our offices that have missed a retinal break. Here's another example of a large vitreous hemorrhage, and this is a subclinical retinal detachment with a retinal break and pigment behind the lens, within the vitreous. Mind you, if a patient's had cataract surgery, if they had other entities that had old uveitis or anything, you can't see pigment in there. But during the acute PVD process, you're seeing pigment for the first time, and you're not finding that break. I encourage you, at the very least, follow it closely or get a second opinion. And here's an example. I just got this one from Instagram. I thought it was a beautiful view of the vitreous cavity, senuresis, the fibrils, and some of the pigment. Another tip I want to tell you, shake that vitreous. Unlike the anterior chamber, you don't have this current where you're actually seeing the cells coming through from the inferior to the superior. You got to shake it. And when you do, you will see them settle downward, much like the vitreous hemorrhage at hand. Joe, any tips with that?
No, I will have them look up and down, left and right too. I'm not going to shake them a lot, but I'm going to, occasionally I want to, but I'm not going to. And I like one of your earlier pearls saying that bringing them back is just giving us another chance to find something. Maybe we had a bad day. It gives you a second chance to find something that may already be there. The vitreous can be this can be a very dark, scary place. Patients don't dilate well. You've got cataract, you got PCO, you have a small YAG opening. It's hard as heck to see sometimes.
100%, 100%. So another patient of mine we just had recently, and I thought this was a cute view. So we have a nice horseshoe tear on the superior aspect. We have a hemorrhage on here, which led, this is not a PVD, this is all blood coming from this one single vessel bridging on this break right here. Patient was treated by my surgeon. Treatment initially, if you've seen it within a couple of weeks, maybe a week or so, looks white. The retina is going to come out and look white. It takes a little while for it to become pigmented. But the reason I'm showing you this is not to show you his beautiful job. He did a great job sealing this area. But the patient followed up within a short period of time, within a day or two post-op. We usually see them within a week, if not a couple of weeks later. And the patient was very nervous because they stated that they had big bird flying in front of their vision. And they said they knew what their big floater was and all the little floaters that were seen. But now they had this big bird flying in front of their vision. Did something happen? Did we elicit another break? Was there an RD? Looked around, I saw the patient. There wasn't anything wrong, except for the fact there is your big bird. The actual, and it looks like a beautiful bird. I thought it was an incredible shape, not of the actual big Sesame Street big bird, but an actual bird. The vitreous gel with the hemorrhage, which was inferior and below the line of sight, after the laser and the dynamics of the vitreous actually moved into the line of sight, which made the patient that much more nervous. But we were able to take pictures, show them that everything was fine, vitreous hemorrhage settled, and the patient did great. But I thought it was a beautiful view of a bird. It was my bird's eye view. I'm going to use that later, Joe. All right, ready? I believe this is a poll question, is it?
Oh, it is a poll. I don't know. I'm gonna go look at it and I'll open up the polls. So we're gonna do poll number 2. Patient doesn't speak English. I can't tell if you're seeing flashes and floaters. I refer just because of the clinical picture. I follow it as a percolated, so it should be followed in 6 months. I follow in 1 month and ask them to bring a translator at that time. Or I refer due to the language barrier since possible symptoms are key in my decision to refer. And people are weighing in. Yeah, Diana, my challenge is when I'm trying to assess for a temporal arteritis, and we don't speak the same language.
You don't? Why?
No, if they speak another language and I'm trying to do a history for temporal arteritis and everything is in the history.
Oh, no, got it. I thought you were alluding to the fact that it
Mhm.
wasn't, an older white male type of because most of my patients, to be honest, don't speak either English or Spanish. Can
Mhm.
get away with a little bit of French, but not really. We got a lot of people from the islands. We have a lot of translators that
Mhm.
need a translator. It's a little difficult sometimes. You remember the good old days.
I do. I don't really experience that where I am now. If there's a language barrier, sometimes it might be Russian or Ukrainian.
Oh, can we move on to this question,
Yeah,
Joe?
I'm going to give this way. The majority side refer because of the clinical picture. Follow, I refer due to the language barrier since the symptoms are key in my decision to refer. I follow in 1 month, ask them to bring a translator at that time, or I follow, it's a percolated, so should be followed in about 6 months.
I would say just about in this particular case, every answer is okay, except I would definitely not just follow in 6 months just because in a percolated hole. And here's why. Every single clinical case is different. You can't just say one size fits all. This isn't a perculum. There's no question about it. But notice a couple of things. Just like Joe mentioned about the capillaries, this is rather acute. There's no question that it is. Look at all the hemorrhages right around the area. There's a small cuff of fluid. But what's so key and important to me is not even that, and it's not even the symptoms, which the patient may be symptomatic. It is the fact that this operculum right now is a perfect puzzle piece. Most operculums, if you notice over time, they shrink, maybe 1/3 or 1/5 the size of the actual hole, because it's no longer being perfused by the retina in and of itself, like the example here. This is an old operculum. I'm okay to follow this particular case, even though the hole may or may not be bigger. But in this particular case, if I am following the patient, I need to follow them sooner, because this patient may have a higher chance of developing a retinal detachment. And that's really what we're trying to prevent. Holes and breaks are treated because of the higher propensity towards a retinal detachment, not necessarily because they have an RD at the time of presentation.
And I think if you go back just a little bit, the fact that the operculum on the right is somewhat robust and there's some hemorrhage there, it does tell you it's acute. Now, when we see these atrophic holes or percolated holes or old flap tears on routine examination, that's a person who's had that for an undisclosed amount of time, yet nothing has happened. They have a track record. The fresh ones don't have a track record. We don't know what's going to happen.
Excellent point, Joe. These come from the 2024 guidelines. Again, I am more than delighted. Just tell Joe, let Greg know. I'm happy to share any of these particular slides. I just can't share the original slides with the pictures, but anything that has words, I'm happy to share any of them. So just let me know and I'm happy to send them to you. But these guidelines are out there and they have the examples at hand. And we're going to talk about the horseshoe tear We know symptomatic horseshoe tears have the highest propensity towards a retinal detachment, hence they're always being treated. Whereby asymptomatic horseshoe tear, they may consider treatment, and that's actually changed guidelines. In the past, they weren't always treated. Now there's a consideration for treatment. I can tell you my surgeon, and each surgeon is different, does treat any horseshoe tear, whether it be symptomatic or not. But then you see things like an operculated hole. Symptomatic ones may be treated, while of course asymptomatic ones are not treated, but they are followed within 1 to 4 months. So that 6-month waiting time was a bit too long. That was the only answer that I think was probably not the correct answer. Any of the other ones would have been just fine. And just like Joe stated, these are guidelines. They're not set in stone. And I'll be honest with you, you might be working with one retinal specialist that may treat a particular tear, and you might send that exact same clinical presentation to another surgeon, and they may not treat it. So now it becomes, what is truly the standard of care? My clinical pearl will be to each and every one of you probably have a typical go-to retinal specialist. Find out what their guidelines are and follow that as necessary, and you're never at fault of getting a second opinion. So this was a really interesting case because at first it was sent to us as a chororetinal scar, but it really wasn't just a scar in itself. I thought it was really pretty to show their perculated hole right over. This is actually a hole. It's just almost like a window defect. There's actually a defect here. This is normal retina left behind, and they're perculating right on top. So technically, it is a break. A retinal break is defined as a tear, as I shown you in the previous cases, flap tear, horseshoe tear, where the apex forms into or towards the optic nerve, and a hole, which could either be atrophic or perculated. Atrophic holes have no vitreoretinal adhesion, which is why most of these don't have a propensity towards a retinal detachment. Perculated holes oftentimes are completely separated, therefore much lower risk towards a retinal detachment. Flap tears have the highest propensity because of the continuous adhesion at the area in question. Here's a nice illustration of an actual break or hole, just as in this case, with the operculum piece right above the area in question. Patient has a symptomatic PVD in these two small atrophic holes. Hold or fold? What are we thinking? This is not a poll question. It's just kind of think out loud in your mind. What would you do? And in this particular case, I hold it. Chances are, like Joe alluded to earlier, that this is an old hold. It was there before, and the patient just has an acute PVD. Needless to say, you're still following up the acute PVD as you would so. You're still doing a great diagnostic evaluation of the entire retina. You may still do a scleral depression, but those particular small holes are atrophic, and likelihood they were there before, need not be treated at hand. Atrophic hole has the lowest propensity towards a retinal detachment, and there may be some variations, and here's a couple of examples that may vary. So here are two examples from our office seen by the same surgeon, but believe it or not, they were not treated the same. And again, my surgeon is very meticulous about seeing each and every patient as an individual person rather than evaluating, well, here's an operculated hole, here's the guidelines, that's how I treat. He treats the person, not the disease. And I think that's important to know. 2 and 1, both large holes, both have small operculums, and we talked about smaller operculums have likely been there for quite some time. Both have small areas of pigment right here and right here. So again, alluding to the fact that this is probably a chronic stage. How should you manage? Well, the top one was an acute floater, status post cataract surgery. Cataract surgery was done by one of my surgeons at Lowell Ophthalmology, and then the patient was referred to Dr. Diaz's office. So I got to see this patient throughout. The bottom one was an asymptomatic inferior hole and was found without any problems at hand. The top one, because it was seen by the cataract surgeon, patient was told by the cataract surgeon about the possibility of treatment. The patient was adamant about wanting to have treatment. He happened to be a lawyer, true story. And my surgeon gave him the option, and the patient's like, I want to get treated. So my surgeon, rightfully so, treated the case and wrote it as such, presented the options at hand. Patient wanted to proceed with treatment. Treatment was done. Where on the bottom, being an inferior break, having a small operculum above, pigment surrounding them, patient was merely educated and it was being followed. But if you looked at the clinical picture, they look very similar. Joe, any comments in regards to that one?
No, I agree. I think those are two that I would not rush to treatment, but you can give a patient an education and let them make an informed decision. But Dana, can you go back 2 slides? There's something I want to ask you about if you're gonna.
Yep.
Now the studies by Norm Bayer and Matt Davis, are you going to talk about those in more detail?
I'm
Or
not.
okay.
No. Oh,
Well,
I know that these were the bases. Is there anything you want to add from a clinical pearl?
Well, it's very interesting. These are very old studies from the 70s. Norm Bayer was the king of doing nothing. And Matt Davis, I mean, this is a person who took a series of patients with known retinal breaks and didn't treat them. He just followed them to see what would happen, and he followed a large series of patients over the course of 16 years. And some of these were asymptomatic flap tears, some were symptomatic flap tears, some were acute breaks, and he just waited to see what happened. Now, it gave us some great information about natural history, but the reality is they were totally unethical. These studies were just ghastly. Where here's a person who knows a patient has got a acute flap tear and decides, let's just wait and see what happens. And if it detaches, I'll put a scleral buckle in. So I don't know.
Good point.
I'm sure he probably had him sign consent forms, but this did not adhere to the declarations of Helsinki. This was research along the lines of Doctors Frankenstein and Jekyll. It was totally, we got good information. It's totally unethical, and we would never ever do something like that again. When they have good treatment, it's like trying something else for temporal arteritis. Let me see if aspirin will work instead of using steroids and see what happens.
But you know what? Like you said, it gave us some great perspective of the natural course, which to this day, it's the same entities that we follow. And that article is referenced every single time a PVD, a tear or detachment is discussed. So it's a great point. I never even thought about it that way. It was a great point.
It was horrible, and I hope those blind patients feel good that they help people out, but they didn't have. Even the early manifest glaucoma trial, where they observed some early glaucoma, couldn't have been done in the U.S. It had to be done in Scandinavia because it wouldn't pass an IRB. And this stuff was like really ghastly when you think about it. He just sat there and watched, see, let's see what happens. And a person develops a macular detachment that could have been avoided.
You're 100% right. In any event, so let's talk about another case at hand. Very similar, a percolated hole, pigmented, small cup of fluid, routine exam, but this patient happens to be a pre-LASIK consult, comes in as a 6 diopter myope to my retina surgeon. Good, asymptomatic, pigment, small operculum, bad. Getting LASIK, although the chances of LASIK creating a retinal detachment from a small hole of any sort is very small. It is a larger hole, and there's a very small cuff of fluid. This is a cuff of fluid. This is not a subclinical RD. So in this case, my surgeon just presented the information at hand, said, listen, you're going to get LASIK. The LASIK surgeon would feel more comfortable if we laser it, but it is up to you. The patient decided to agree and proceeded to. But then again, it is a conversation between the surgeon and the patient getting it. So not every operculated hole is being followed. Not every operculated hole is being treated. This one got sent to me not too long ago, referred for possible retinal detachment and a tear. Beautiful little heart-shaped tear, by the way. So let's talk about this. Dark area, it's heart-shaped. Remember that I showed you with these flap tears, they're horseshoe tears. They literally look like a horseshoe with the apex pointing towards the optic nerve. Duoscleral depression, it does not open, it's still flat. That whole entire lesion, that white lesion, there was a similar appearance on the nasal side. It does have a scallop border, and in reality, when you're looking at it at the 90, even though this view makes it look like it's elevated, it's actually flat. This is nothing more than white without pressure with an area of dark without pressure within. But they can look very similar to a retinal detachment with a retinal break. Here's another example. We can definitely see that this is from a website. This is not my case, but you can see this is a flap tear with a hemorrhage. You can see the opening, the vessel overlining it. Here's your RPE. This looks very similar to a horseshoe, but note, the actual apex, the course, is not going back to the optic nerve. It's actually turned around. So that could give you one clue. The other clue is if you look at it diagnostically with a 90 or your sclerodepressor, you will notice that it's completely flat and there's actually no flap overlining the area. But they can look very similar. This is a very common case that we get all the time. Lots and lots of lattice, especially in a young patient. So they're very worried due to this substantial amount of lattice throughout, and they all have variations of small holes. Should this be treated or not? You could always get a second opinion, but I can tell you for the most part, my surgeons are not treating this. The propensity of lattice leading to a retinal break is, a retinal detachment can lead to a break, but a retinal detachment is actually very, very small. This is a thinning area throughout the retina. And having said that, with that much lattice, what one would have to do is laser at 360. On a young patient, you're decreasing the field of view of that patient. You increasing tremendously an inflammatory response that can lead to secondary complications. And the chances of this causing an actual retinal detachment, it's still very low, even with a substantial number. We'll talk about other cases where patients had lattice in one eye and a retinal detachment in another based upon studies at hand. But most lattice are followed 6 to 12. Yes, Joe?
Also, when you go back to that lattice,
Sure.
that's as you said, that's a lot of laser energy, and that laser energy will cause vitreous contraction and can actually lead to retinal tears in otherwise normal areas. I have seen that before.
I have a case. I have one of those cases to show you next, to show you that every single treatment is not benign in nature. Great point, Joe. So here's an example of lattice. Again, this one did lead to a retinal detachment, but if you notice, it wasn't the lattice itself, but it was the tear adjacent to it. A tear adjacent to lattice will always get treated. And to give you a representation to what lattice really is, it is thinning. This is a great representation of an OCT. This was actually by Dr. Mo Raffatari. And you can see the thinning area throughout, almost like the ripped jeans I used to wear back in the 80s. This is a snail tracking, which is actually a predisposition to lattice. And as you can see here, the lattice, because of the thinning area, the vessels above it become sclerotic, but there's a tight area of traction above it. And there's vitreous gel surrounding that area. That tight traction can lead to a break, and that gel can cause a detachment secondary to seeping through a hole, which is why sometimes the ones with holes, they watch it a little more carefully. But again, the propensity is very low, and hence, since the treatment is not benign, most of these lattices are followed. When to consider treatment for lattice? Well, then we're looking at a retinal tear as an example here adjacent to the lattice. We're looking at a symptomatic because of traction. You can see that the lattice here, this lattice-like shape of sclerotic vessels and the large tear. And sometimes if there's any fluid, or you can physically see the traction. But if there's traction, you typically will actually get a symptomatic lattice. Folk, and I'm going to show you an example, actually had a case before, talked about prophylactic treatment of lattice in a contralateral eye with patients who had a retinal detachment in the other eye. Because of that study, eyes with atrophic holes or lattice degeneration in a fellow eye who had the contralateral eye's history of a retinal detachment, the consensus is still out regarding treatment. You will see some retinal specialists will treat that lattice. You will see some retinal specialists won't. So there's really no true guidelines, but those who seek to treat those really and always quote Folk's study back in 1989, because he showed those who were treated had a lower propensity towards a retinal detachment, but the percentages were still very low in both groups. Again, this is a snail tracking. As you can see, it looks like a track from a snail. There's a small area of hole. This is predisposition to lattice in itself, which can have pigments. They can have holes in the area. And oftentimes you'll see the sclerotic vessels surrounding the area above it. Another great example by Mo through an OCT, where you can see the cystoid changes around lattice. Look at the cystic changes here in a small cup of fluid and the actual holes and separation throughout, looking straight into the RPE.
Right.
Fold or fold, small symptomatic break. Joe, what do you think of this one? It's small, but it's symptomatic, and it is a flap tear. There is a break with continuous adhesion.
Well, the fact that it's symptomatic tells us that there is a dynamic phenomenon that is actively trying to lift that retina up and wash liquid fluid underneath. You know, when I explain flashes to patients, I tell them the retina is a dumb animal. It doesn't have pain, it doesn't have temperature, it doesn't have a sense of humor. All it knows is light. So if something physically stimulates the retina, it tells the brain it's been stimulated, but it's nonsense. That's flashing lights. That tells us that there are forces that are active trying to lift that flap and wash liquid vitreous underneath. So the fact that it's symptomatic means that it should probably be considered for treatment. Just like, you know, a little bit of papilledema doesn't mean little brain tumor. Okay, it can mean big brain tumor. So little flap tear can lead to big retinal detachment.
It's excellent, excellent. I'm going to show you a micro tear that still led to a nice retinal detachment. It was actually missed, but the micro tear was picked up. The actual retinal detachment was not. So it was still sent to our office. And it's funny that you mentioned that, Joe, because I honestly do use that sense of the retina is like a dumb animal who doesn't really feel pain. I've never talked about the sense of humor since it does have a vitreous humor, but I like that because I do use that in corresponding flashes. Hold or fold asymptomatic flap tear. This is an actual case of mine, but given the fact that it's such a large tear and the consistency now is that there is consideration of treating any flap tear, symptomatic or not, based on the newer guidelines, I can tell you that my surgeon does treat this particular case at hand. And here comes the atrophic holes. So with atrophic holes, we talked about that they have a very low propensity. There's no vitreous retinal adhesion here. It is thinning, insufficient oxygen that led to it. But by the time you start seeing some fluid, you have to start making decisions. Why? Because there is fluid. There's vitreous cavities, vitreous gel reaching, separating the neurosensory retina from the RPE. Now, in this case, this is a subclinical retinal detachment by definition, signifying that the fluid extends one disc diameter beyond the hole. So in this case, given the fact that 1/3 of subclinical retinal detachments will lead to a rheumatogenic true retinal detachments, these are often treated. So you kind of have to gauge what this fluid means. Is it just a little cuff of fluid? Is it a much larger area of fluid? And of course, pure fluid straight through here, we're talking about a retinal detachment. 18-year-old white male floater, status post-trauma, does have a little pigment. It does seem like it was percolated. There is an area of fluid. How would you handle this? You can say you might want to follow it, but there's too many things against you. One, he's 18. The chances of him coming back after his mother dragged them the first time around to come see us, who, by the way, got into a fight with his best friend over, what do you think, Joe? It was
A girl.
Of
A
course.
girl.
He lost the girl, but he gained a hole, so good for him. But in any event, his mom dragged him to this visit. So he's not really reliable. It is traumatic, and you do have fluid. It should be treated. And the actual guidelines do state that traumatic breaks should get treated. because you've changed the dynamics of the vitreous and the vitreous is more liquefied, gaining access more quickly to the subretinal space. I believe this is a question, Joe.
All right, we'll get that up in just a second. So I'll be polling question number 3. Which of the following retinal breaks will always get treated? An atrophic hole, an asymptomatic operculated hole, lattice with holes, and a 4 diopter myope, or a symptomatic flap tear and a 1 diopter hyperope? Okay, things are rolling in. And we are actually caught up on the questions, so we're good.
I can reveal.
Not yet. Well, I'm going to give them a few minutes to opine, but there is a clear trend going down. Which of the following will always get treated? Or
Joe,
maybe
do
we
we
can.
have any questions from the audience that we can address?
No, we are actually all caught up right now. Once we're done with this, I'll go to the other screen and look for you, but I think we're all caught up.
Good.
All right, so we have a clear trend, so I'm going to display, and the vast majority are saying what we all think would be the correct answer: a symptomatic retinal flap tear and a 1 diopter hyperope, followed by lattice with holes and a 4 diopter myope, followed by an asymptomatic operculated hole, and a few people picked up an atrophic hole. So we are good to roll.
So the recipe for retinal detachment, you need a liquefied vitreous, you need a PVD, and this is a rheumatogenic, I should say, retinal detachment. We're not talking about tractional, we're not talking about serous. So rheumatogenic retinal detachment. Rheumatogenic means break, means that you need a break, and then you need the liquefied vitreous in that area of traction, PVD, to lead to the retinal detachment. Therefore, we have to make sense of which breaks have a high propensity towards a retinal detachment, like the symptomatic flap tears, and which don't, like an atrophic hole. Then there's everything else in between. And there are clinical pictures that may vary throughout the patient that still may lead towards on the side of the treatment. But whenever you have a question, get a second opinion. It's okay to get a second opinion. These presentations, I can tell you, were all treated by my surgeon, and I'll give you this one later on. But this one has an acute PVD, symptomatic. It is a very small operculum, some fluid, but given the acute nature, the symptomatic and the mild fluid, it was treated. This is a micro tear, but it is a flap tear, symptomatic, also treated. All dialysis, traumatic in nature, are always treated. Too much of a large area, and they're usually younger patients. This operculated hole, so you can see that even a very small, just like Joe said, small holes, even operculated, can lead to a retinal detachment. So it's hard for us to say, if we've had a chronic hole there for a long period of time, there's pigment. Look at this one. This one almost had its own laser, if you will. Fully pigmented operculated hole. You can feel incredibly comfortable to follow this. What else can they possibly do? They can't laser anymore. It literally has full pigment. But at the end of the day, lattice in itself, you can see the pigmented areas throughout lattice, very low propensity, are not going to be treated. Small cuff of fluid on an atrophic hole, there's no pulling, not likely treated. An operculated hole, even with fluid, asymptomatic, are not likely treated. But I've seen these been sent for a second opinion. To treat or not to treat? Definitively, giant tears, dialysis, these are large areas, usually traumatic in nature, are going to get treated. Horseshoe tear, definitely symptomatic. And I would urge you to get an opinion on an asymptomatic one. I definitely think most of those will be treated. Which ones are likely watched? We talked about lattice. We're going to discuss retinal tufts, because I'm going to show you a tuft that actually went bad and why tufts may actually go the other way around. Atrophic holes and operculated holes. But again, it is not just a general presentation of the break. You got to look into, is there symptoms with any of this? Is there associated fluid? Is there traction? Those things may lead towards treatment at hand. Here is an operculum. You can see it right down here. It's a large hole, it's asymptomatic. If the patient has had flow, I shouldn't say asymptomatic. It's asymptomatic, meaning they've had floaters for a long period of time. So myopes have had floaters for long. They're not symptomatic, acute symptoms now is how I should have put it. But they are 9 diopter myope. Would they or would they not be treated? I will tell you there's some surgeons who may treat. Why? Because there is an increased propensity of having any kind of break in a myope have a higher chance towards a retinal detachment. Just by being a moderate to a high myope, you increase your chances of retinal detachment. So at the very least, you might want to get a second opinion. So outside of the breaks that we show you, even the fluid, you want to take a good history. Contralateral retinal detachment and or break in the other eye, somebody may treat some sort of break, even lattice on a contralateral eye. First degree relatives with a family history of retinal detachment, but what they're really looking for is these anomalous vitreoretinal diseases. Any kind of traumatic hole, high myopes, or someone who develops a retinal break status post-surgery. The new clinical preferred practice patterns do add questions about procedures such as injections. I've actually seen a break induced by an injection, and the recent miotics and the presbiotic drops. Anything you want to say about that, Joe, with the presbiotic drops and association of RDs?
Yeah, I'm not sure how I feel about it. I'm not sure how strong the literature is, or if I'm just not up on the literature. We used to use 4% pilocarpine all the time because we didn't have many medicines. And I guess anecdotally it could lead to retinal attachment, but then again, how would you ever know? Because whenever we started, back in the 80s when we prescribed pilocarpine, before we did, we had a going away party for the patient's retina because that's about the last time we ever saw it again because we could never dilate those patients. So I guess there is a bit of a risk. I'm just not sure, how much is founded based upon the research that we had, in the 70s and 80s, and was that even, are these really even legitimate concerns?
They did a case study here at Bascom to prove that there was an increased risk. But Bascom, everything gets sent and filtered through there. So the worst of the worst get through there. But they did find an increased risk. So there's been some questions. There is some new drugs out there with smaller percentage that supposedly have a lower risk. So it's up to you to decide. But at the very least, I would document information that you educated the patient. When looking for a retinal hole, note the adjacent findings. In this particular case, there may be some fluid and there are some hemorrhages, and there is definitely a history of trauma. This one would definitely get a referral and likely treated. I think this is the last polling question, Joe.
Okay, I'm going to pull that up for you. So which is not a risk factor that might increase the propensity for a retinal break to progress to a rhegmatogenous retinal detachment? Symptoms, type A personality, associated fluid, or a retinal break following cataract surgery? So what's not really a risk? What is not a risk factor? What is something we're not going to consider in our decision tree? So people are weighing in. There's a distinct trend going on.
I like these trends.
We'll give them a few minutes. And when I last looked a few moments ago, we seemed okay with I think we're caught up on the chat room questions.
Either they're exhausted or we really have answered every one of their questions. I'm not sure which one.
I think they're picking up what you're putting down. So I'm going to put an end to this because there's a distinct trend. What is not a risk factor? A type A personality and that comes in at 93%. But the presence of symptoms, the presence of an associated subretinal fluid, and a break developing after cataract surgery are probably considerations that we should all have in terms of our decision making.
Excellent. Although type A personality certainly has been associated with other entities such as central serous choroidopathy, it isn't associated with vitreoretinal adhesions. Associated signs and symptoms that you may want to consider. So we talked about cataract surgeries. We talked about even miotic drops. We talked about the case history. But now when we're looking at the tear, we've alluded to many of this. Symptoms is the number one reason to treat. Associated fluid may or may not be a reason, but I would urge you to get a second opinion. Large holes, sometimes I've seen my surgeon do treat very large atrophic holes. Any kind of traction, and over here we're looking at a particular break with somewhat traction. You got to look at this traction carefully with a 90. You're not going to often find that vitreoretinal adhesion. It's too far away from you to pick it up with the 90. I'm sorry, with the BIO. Remember that the BIO and the 20 are allowing you to give you a larger field of view in lieu of giving you lower resolution. So pick up that 90, take a look at the area in question. You'll be amazed at what you can see at hand. In lifestyles, I've had tears being treated in boxers just because of their lifestyle. Remember we talked about the retinal tuft at hand. There are two kinds of tufts, and I'll show you the clinical pictures. But there is a cystic tuft and a tractional tuft. Believe it or not, the cystic round tufts have a higher propensity towards a retinal detachment from a retinal break. In these more triangle-like shapes, oftentimes those break fully. Think about the retinal tuft triangle shape like being vitreomacular traction. And if you think about vitreomacular traction within the macula, the full traction will lead to a full thickness hole. Those are your operculated holes. That's actually where most operculated holes may come from, or many of them do, whereby a larger area of cystic traction oftentimes has some pigment surrounding it. It's a stronger area of adhesion. So if there's a pull, it's not going to be a complete pull, and it could lead to a break. So this is why symptomatic vitreoretinal tufts may be treated. And those are not symptomatic, especially the rounded ones, should be followed a bit more carefully because they can lead to a flap tear, which can lead to a retinal detachment. So as I pointed out, these are the cystic ones, more rounded, stronger, larger area of adhesion. So the pull's not going to be complete. The triangle ones, typically, if they pull, they'll pull completely into an operculated hole. Hopefully that makes a bit sense. Here's another example. You can actually see the tuft, rounded, was pulling, led to a flap tear, even with pigment, so it's a bit older. The cystic changes here, it's not because there was a retinal detachment with cystic changes. This was a retinal schisis, and the fluid got through that area, gaining access to the subretinal space, and this area past it is a retinal detachment. So even a schisis, you can see develop into a retinal detachment. We'll talk about that towards the end. Here's a great example of an actual, not only a tear, you can actually see the hemorrhage here. This is the flap tear, but all this area is fluid. So there is actually a detachment. This was missed out in the original view of the Optos view, and it was treated by my surgeon. So you can see a nice little treatment, just literally a day or so in the vitreous hemorrhage in association. Here's some blood. Symptomatic flap tears, we talked about this before, high propensity towards a retinal detachment, up to 50%, hence those get treated at hand. Here is, by the way, proper treatment. It should be fully encircled. It shouldn't be just treated on one side. I don't know what that surgeon tried to do on this one, but here's your tear, and this is your treatment. There's no more treatment here. Not quite sure what happened in this particular case. This was an older case that we saw, which I re-referred back to my surgeon. I said, I think we should add some treatment on this, even though the patient came in with history of a treated laser tear. But you want to look at them, you got to have a full treatment at hand.
You know, Diana, the interesting thing is if you go back to a proper treatment, you know, there's a fair amount, depending on the size, there's a fair amount of energy that's put in there. And if it isn't thoroughly treated, the risk is the laser has now caused vitreal shrinkage and may actually increase traction. And the suboptimal treatment is not some is better than none. It's not a good philosophy, because it could actually make them at more risk for detaching. if the
That
treatment
may
is not
may
complete.
have been what happened here. Maybe this was smaller and the traction itself pulling on one side caused it to, but this is not, I don't even understand how this was treated.
Hmm?
You clearly can see the laser here, there's none here.
I saw a patient, it was a large retinal schisis with a tear along the edge of it. And I frankly didn't know what the risk was, and I sent him to a retinal specialist with whom I worked at the time, and he acknowledged he didn't know what the risk was, so he decided he would treat it. He did a beautiful treatment, and he sent the patient back to me for follow-up, and he had a beautiful treatment right around that retinal schisis area. It encompassed the tear, and right next to that beautiful chororetinal scar is a big flap tear, which developed subsequent.
That's and I have an example like you just mentioned.
Mhm.
Location of strong vitreoretinal adhesion, as we mentioned before, obviously by the nerve, hence a PVD. Macula, hence things like VMT and macular holes. Lattice, hence a tear adjacent to it, not the lattice itself, the thinning, but the tear adjacent to it. And of course, areas of the vitreous base and the aura, which is what Joe had mentioned. That's where you want to get a good view. Here's a nice illustration of what we're looking at. Here's a hemorrhage. Here we're looking straight into the RP through this area. You can see that the tractional pull is incomplete. So therefore, higher propensity towards a full detachment, as we can see the retina lifting from the fluid gaining access to the retinal break. So this beautiful taco shape was one of my favorite pictures of a giant tear. Giant tear elucidates past 3 clock hours, but anything past, I would say 2 already gets you into the ballpark of a giant tear. And the reason why it flaps down is that it didn't pull off the aura like a dialysis would. It is secondary to trauma oftentimes, but it pulled away. You can see the scattered effect. My surgeon, and this was my previous surgeon, actually did a retinotomy, and it's not a hole in a case, but the retinotomy was literally cut off that part of this retina that was dead and wouldn't fall backwards. And the other thing he wanted to use is this very heavy fluid called PFC, which he literally rolls the retina back and then lasers for it. I wish I had the post-up photo of this one because it was a beautiful picture and the patient was back to 2020. But I actually did have a large area of a visual field defect, and it was a traumatic case. A dialysis, just a little bit different. A dialysis will zip away, so it's not breaking. You can see part of the retina here and here where it broke. This is an actual dehesion, an actual separation of the retina at the aura by the vitreous base, almost always associated with trauma in itself. Key thing between them both, the giant tears associated with a PVD. There is pulling. This area, the dialysis, is not. Hence, the dialysis being in a younger patient and no PVD, oftentimes will not get a vitrectomy, because if it does, a vitrectomy can lead to other problems due to the pulling and dynamics of the vitreous, so that oftentimes just gets a scleral buckle, which is almost like a dying surgery nowadays. Do your surgeons still do a lot of buckles? Mine do, because they're Bascom trained. So at Bascom, they still do it. Not every time, but when necessity. But I think a lot of older surgeons don't. Do yours?
The answer is it all depends where the person was trained, because you mentioned they trained at Bascom, where if they do buckles. No, we don't. The surgeon we have in our practice does buckle, but not a lot. There are some people we work with in the general area that will do a little bit more in terms of buckles. But you're right, it's all given away to vitrectomy.
True. And it comes from the studies itself that had proven vitrectomy is as equally effective as a buckle. But there are definite cases, young patients, large tears, no PVD, a buckle will be a necessity.
Now, before you go to this question, because I see some key words here, a question did come in.
Sure.
Where Natalie's asking, sometimes I see pigment in the anterior vitreous after phaco and IOL, and this gets confusing when trying to rule out a retinal break. What are your thoughts?
Excellent point. And I think, Natalie, that's a great point. And I had mentioned before that if you see pigment on a patient who didn't have an IOL, who didn't have a uveitis, you're sure it's Schaefer's sign, then that's going to be blamed on Schaefer's signs. But there are other times that it's not. So much like Joe had mentioned, if you felt pretty comfortable with your examination, you're scleral depressed, maybe follow up the patient closely. But at the very least, if you feel uncomfortable, you could always get a second opinion. But chances are that really did come from the lens in itself rubbing on the iris and not to do with RPE dissemination or vitreous hemorrhage you're not seeing. So very good point at hand. Pigmented cells on this patient, anterior vitreous, posterior vitreous, you have large PVD, inferior hemorrhage. Very large tear. I would call this technically almost a giant tear. And in addition, they did have a break in the other eye, again, associated with lattice, believe it or not. Laser was done, but patient comes back and look as recent as 1 week post-op will always still give you that whitish appearance before it becomes pigmented. 2 weeks after surgery, she's experiencing new flashes on the right eye. And there's your new tear. And chances are that that laser that we had shown you, that was done kind of immediately after laser, and we just take the picture on it. But if any new flashes or floaters come about, you always have to look at the patient again. And this could have been elicited by the laser itself, could have been elicited just because the vitreous is pulling along the areas, but about 15% of patients who have new signs and symptoms after an evaluation is done, after surgery is done, they likely developed a new break, and you got to look for it at hand. So the laser itself can even induce dynamic changes into the vitreous cavity that can pull away into another area. So last summary, again, a slide that I'm happy to share as a nice little clinical pearl summary. Considerations when you're looking at a break. What kind of break? Is it a flap tear? Is it a percolated? Is it an atrophic hole? Each have a different propensity towards a retinal detachment. Does the other eye has had a laser treated break and or retinal detachment? And now you're finding in the contralateral eye a new break. Is there acute PVD and a break? That's a treatment at hand. Does a patient have risk factors such as myopia, trauma, cataract surgery? We talked about when we could consider lattice degeneration and surgery. We're going to get more into schisis. We discussed the retinal tufts and symptomatic, or the rounded ones are the ones you want to follow closer, and symptoms being the highest propensity towards a retinal detachment. So it's 4 o'clock on a Friday. The regular ER shuffles in. I did this for you, Joe. I know you're a Billy Joel fan. There's an old man sitting next to me telling me how he sees his floaters within.
That's pretty good.
What's the critical question when you call my office at 4 o'clock and you want this to be seen by my retinal surgeon? I'm sure everybody's got the right question. You're asking yourself, insurance, yes or no? It's incredibly important. No, truth be told, I actually do ask about insurance. That's actually almost my number one question at hand. But macula on or off, always important. And I'm telling you right now, photos don't tell this whole story. You would say this macula is 100% on, but it is 100% off. And it's very difficult to tell. There is actually fluid. It only needs a little bit of fluid seeping into the macula. If the visual acuity is affected, the macula is off. And I've told that to my colleagues over and over again. I've had colleagues who swear the macula is on, but the visual acuity is 2400. Unless you're looking through a cataract, unless you're explaining to me there's another reason that macula is off. And it doesn't have to be a 2400 eye. It could be a 2050 eye. But now it's going to make a difference of getting the patient quick to us and for us to decide of surgery done that day or the next day. Another clinical pearl I want to give you when doing an OCT, this dense area forming here and here is actually more common with patients who've had retinal detachments. They're a bit more chronic, usually over a week or so. In this patient, one could tell that if you kind of block this area in question, it could almost look like a central serous. But it was a full-blown retinal detachment, a low, shallow RD. So you got to be really careful when you look at these entities at hand. When we're looking at asteroid halitosis or anything within the vitreous, it makes the view very difficult. But I'd urge you to get your other diagnostic modalities like fundus autofluorescence and an OCT to help you liberate a better view within the retina at hand. Let's talk about some obscure cases. This is an example of that micro tear. You look at the examination, you look at the optos, and you say to yourself, everything is fine. But look outside of the view. The doctor did pick up on this very small, very, what I would call almost a micro, but it is relatively small tear, but missed the actual retinal detachment. And it wasn't a very highly elevated RD, but there's full-blown fluid. It's a difference between having the patient be seen within a day or so or having the patient be seen within a week. Patient did get a full buckle on this particular case, I believe because the patient was young and phakic, but they did have a PVD. A vitrectomy could have been done for that reason, but given the fact that we're young and phakic, they did a buckle. And when a buckle is done, oftentimes you'll still see the whole area elevated, but one larger elevation pulling at you is that extra silicone is placed for reinforcement at the tear site. Sometimes cryo laser will be applied there as well. Very retinal detachment here and a very nice representation of a retinal break. But again, you would say this is macula off. These are real cases. In this particular case is macula on. Literally, the retina is folding over the area in question. Decreased visual acuity maybe, but the patient could actually see better by literally moving their head forward and backwards alone. That becomes far more emergent than a case where the macula was off. Same patient, 1 month, status post, fluid gas exchange, or 2 different gases that we use within our office. Endolaser and vitrectomy. Patient is doing very well. You see the fluid, you see the gas bubble. The patient returns within 3 weeks rather than the month post-op. Why? Because they're worried they're seeing extra bubbles and they want to make sure that they're okay. Reason why they're seeing extra bubbles is there's their little bubbles. You can see the cryo area for the laser from the question tear. 6 months later, floaters now in the contralateral eye. Perculated tear that was treated, going back to the case scenarios that we gave you. Patients already had a contralateral retinal detachment, very large retinal detachment. So we're going to be a little more careful if we see any kind of breaks in the contralateral eye. Very different if the other eye never had an RD. This operculated hole may have been followed. Another example of vitreous debris and trying to get through that view, little difficult to tell, but note here and here, this patient had a retinal detachment. So these are real cases and you got to be very careful when evaluating these patients. This one, note a little bit of the wrinkling, was sent in as a potential hypotonic eye, but the IOP was actually normal and there was no reason to be hypotonic. They thought it was choroidal folds, but it was actually undulations on a shallow retinal detachment. The more diagnostic modalities you have, the better it is to evaluate some of these cases. And I'm showing you subtle ones at the very least. This is a little more difficult at hand. You can see overall it looks more or less okay, but really what is happening is a full-blown retinal detachment. Another one of our cases, you can see some of the folds, very large retinal detachment. This whole entire area is detached. This area right here is the only area that's actually somewhat attached. Everything else is fully detached. So some of these pictures, just to give you an obscure presentation. I'm going to finish and not take any more than 6 minutes of your time. Retinal schisis and detachments. Here's an example of a large schisis, cystoid changes, white without pressure. Oftentimes we get these schisis sent to us as retinal detachments and people want to know, how can I tell the difference? And we're going to go over that. A schisis is typically fluid-filled cystic changes collecting in the area between the inner and outer retina, separating the retina. That in itself has very low risk of developing a retinal detachment. But there are different forms of it, and because the retina thins out, holes can develop, allowing for the vitreous cavity to gain access to the subretinal space. An example are these outer retinal holes. How do I know they're outer retina? Because in the outer retina, they will fold. You see this fold right here? So oftentimes what you will see is this whitening surrounding it. That's an outer retinal hole. Inner retinal holes within this superior aspect usually have this whitish-like appearance to it. So it's in the outer retina, the second part of the cavity. Here we can see some of the cystic changes at hand. and the little gun spots right here, all these representations of the Mueller's foot plates and indentations within the outer retina. The vessels overlying that inner retinal cavity are going to become sclerotic, much like in lattice, because it's thinning area. Great representation of Mueller cells stretching between the inner retina and intact outer retina. Again, giving you representations, what we are looking at. I think retinal specialists are amazing at finding this, not because they have better eyes than us or because they've had longer period of time in clinical care, but it's because side of the eye, they anatomically truly understand all the layers within the retina, the pathophysiological changes that occur. So if we get better at analyzing things through all our diagnostic modalities, we actually become better clinicians at hand. Various representations, some are my own and some come from the website, of patients with variations of schisis. They could be opaque, they can be translucent, they can have sclerotic vessels, they can have cystic changes. Again, outer holes, notice this white edge, that's a little bit of a fold that occurs only below on the outer aspect of the OPL. So, schisis on one side, RD in the other. How can I tell? These are my best clinical pearls that I can share with you. Almost always look at the other eye. In a schisis, you will often find either another schisis, small, shallow, or at least cystic-like changes. Schisis are more commonly inferior. They're opaque or translucent at hand. Scleral depression is very helpful. When you scleral depress, because it's all the same fluid, it will move on itself as one single unit. A retinal detachment will undulate and collapse in and of itself. Look for pigmented cells in the vitreous. Look for a retinal break. Is the patient symptomatic? That's on my side of the retinal detachment. Unilateral presentations, more likely RDs, but I've certainly seen schisis that have been unilateral, more likely bilateral, at least cystic changes. Another comparison, translucent outer retinal holes. Notice this bubble-like appearance with a dome shape. That's a schisis. You can actually use a BIO. This actually does work. Light up a light into the area of the schisis. Ask the patient if they see it, the light. If they don't see it, chances are it's a schisis. They can actually see some aspect of the light, although attenuated through a retinal detachment, because some of the communication is still going through the different layers, where in a schisis, because of the typical split through the bipolar, you will not get any more information at hand. Here's an example I got just today, so I want to bring it up. And I don't want to give you the answer, but tell me what you think, schisis or an RD, now that we kind of learned about it. Cystic changes in the other eye, inferior, asymptomatic, no break, no pigmented cells. So likely, this is a schisis at hand. And these are other examples of schisis. When should we manage? Well, schisis can have holes or breaks. I might get a second opinion on those. Any schisis that progresses, they may even lead. This is a schisis on this side. Notice all the variable outer holes. Notice the actual folding around the area, but this is a retinal detachment. So they can lead to an RD. This is a particular schisis on this side. This was treated previously. That progressed, hence it was treated. And here is a final schisis, outer retinal hole, leading to a retinal detachment. Notice the difference here. Notice my indentations here. Notice the cystic changes. Notice the outer retinal hole. And this part is the RD. That's a wrap, my dear.
Well, that is fantastic. I'm going to have you stop sharing, and then I'll take over.
Am I stop sharing?
Nope, you're still sharing.
Oh. I wanted to dedicate this to my poor little puppy. One thing I do want to say, guys, and I forgot that I wanted to say this because I added this the other day. My dog had passed away this weekend, but the real essence of this is no matter what kind of diagnostician you are, for patients, they really don't care how much you know until they know that you care. And that really is so true. So regardless of any of the clinical pros we can share with you, keep that compassion, because that's going to go a long way and make you a much better clinician. So I did want to share that at hand. Now I'm going to stop sharing. So I'm glad I put Puppy in
Very,
there.
very nice. We missed Butters. They're very sad. I actually have a pet named Butters, but Butters is a snake.
She's
Yeah, my Butters is a snake. Well, Diana, that was fantastic. I think you got through all the questions. You can just tell that you have a wealth of experience and a very strong passion for this, and a good way of talking through people, to people, and not down to people, talking to people and talking them through this. So we really do appreciate it. I think you did a fantastic job. And I think that you're getting your virtual round of applause. Everybody's thanking you, thank you. Sorry for the sorry for Butters, and you get a lot of sympathy for that.
Well, I thank you guys, and I thank you, Joe, and honestly, very much enjoyed it. Thank you, Joe, for sharing your clinical pros. You gave me a couple of things to think about for my patients tomorrow, so I thank you. And for the audience, if they do want those slides that I promised with the words, I'm happy to share that. Any questions they may have in the future, happy to answer. Thank you again, and hope to see you in the near future.